and it can be sent through emails. Anyone interested, give the email to Dr. Saad, please. Now, I think also we should make use of all the latest technology in fighting diseases and blindness as well. And we have lots of changes, in fact, and there are many jumps in the treatment as well as in the diagnosis and screening. Especially this applies to a large country like ourselves and remote areas, and also unavailability of those who can do proper screening with indirect thermoscope, because in fact learning indirect thermoscopy is not an easy job, unlike direct. That's why I think we should make use of all our tools for proper screening. From this all busy slide, we know now it is a disease of prematures. The smaller the child, the more the incidence of the disease. But now in ROP there are few epidemics, we call them. You see, in the early 1940s, 50s, they say that we need the oxygen is the problem, and they tried to curtail the oxygen, and there was problem with cerebral palsy. They said, no, I think this is now, we need live babies even if they cannot see. So they sort of leaned less on oxygen, and sort of hoping that they will preserve more of the infants or blindness. But then a problem when you curtail the oxygen, now the supply to the brain is a problem, and that's why lots of cerebral palsy came. So now, with the advent of nice neonatology services, we are saving very prematures. Now, even 22 week of gestation can be saved, and this caused another epidemic of ROP, and this came at around late 70s, 80s, and that's why all the incidents rose quite dramatic. Now also with the IVF, with multiple pregnancies, small babies coming, and also saving younger babies, the rise of the prematurity itself is in fact going so high, and this will produce more ROP, because the smaller the baby, the more problem here. And you see all these statistics we talked about, and I think the main thing that we are producing more prematures, and I think now you see the good thing about retinopathy of prematurity, that it is a clinical diagnosis. We don't need labs. We don't need fascinating imaging. We only need to examine the retina. And also their classification, as you said, is very good, and also good treatment, and we know we can prevent this. So if we screen and catch this patient early, we can do a very good job. Now, regular screening started many years ago, but now this the first report on tele-screening of ROP was at 2000, and the group headed by Dr. Tracy, he came for our ROP workshop as well, and I visited him many years ago in Michigan, and he they reported in 2000 using telemedicine evaluation and screening of ROP, as well as Ellie from Canada. They reported good sort of pictures that can be read even remotely using the wide angle camera, and at that time the RedCam was the only available one. And in fact, this is, as mentioned by Dr. Albar, the photo ROP defined that it is quite good to use these digital images, and now the recommendation is to do a posterior pole shot and then nasal periphery and temporal periphery, and then you can send it remotely. You can read, and then you can also send back your the feedback and plan of management as well. Now, at present, many studies have shown the good specificity and sensitivity of these digital cameras as a screening tool. And earlier on, there was a problem with the camera because the lenses were big for the small babies. But later on, with the development of a smaller camera that can fit into the small babies, we can reach to the periphery in a very nice way, and also the resolution is very high. And you can imagine here, this is, you only see it with the 28 diopters, or even less than the 20 with the 28. Now you can see the optic disc and also the periphery. You can see very nicely the ridge, the new blood vessels. Once you see the ridge coming from white to pink, this means that there is extra retinal new blood vessels. And this is all the many reports, in fact, and this is the meta-analysis by the American Academy of Ophthalmology of using wide-angle retinal imaging as a way of digital screening, and it is from a reading center, and it is recommended by to use this, and with no cases have been missed of they end up with a late ROP. And the best thing is that, in fact, it is quicker and faster to do an exam with a camera. Look at this. For example, there are few papers on this, but this is take 1 minute to get a complete shot and exam from camera. 4 minutes, almost 5 minutes, to do an indirect thermoscope exam. And also, if you do the all cumulative time for many patients you are talking about, this is it will save time for this. And not only that, but also it is less stressful for the infant. And we know that the exam is stressful. And as mentioned by Dr. Hajar, we use also the spade depressor or rotator. It's not, we don't need to depress, but the main thing is to rotate the globe. With this serration you apply to the conjunctiva, so that to rotate the globe, because the patients cannot look right and left for you. Just you are doing this for. But with this, with the speculum and with the little pressure, we sometimes have bradycardia or apnea, and we need to stop. And this we use it very common when we were doing cryotherapy for the treatment. But the exam itself with the fundus camera handheld, it is there is no stress to the child. In fact, we need only just a speculum. And also probably the digital or at the leisure time of interpretation, that compared to indirect thermoscope, we can detect earlier changes of ROP by the digital camera compared to our indirect ophthalmoscope. But probably these are not very significant for the management of the patient. But this, it means that with our digital system, this is even more than sensitive than our indirect thermoscope. Now, this is also an issue about the cost of these digital cameras. The cost per camera, it is quite expensive. Now the one we have, it's around, you are talking about more than $500,000 per camera. But now there are more coming to the market, and the competition will make it getting less. Now it is coming down to 200,000, 300,000. But now you are talking about one purchase. And they compared for a setup, compared once you have camera or with the physicians, because also the physician will cost you outpatient visits and also follow-up visits or paid, and this is from This is from insurance companies in the US. They found that even the using digital screening is more cost effective than asking the physician, usually retinal specialist, to come and do the screening for you. Now this is at 2000. This is where they say the sensitivity is low. However, with recent publications and a prominent guy from Switzerland, Schwan Dai, also he came with our workshop, and he wrote about telemedicine, and they said, I saw it in Auckland, Greater Auckland, and now in New Zealand. They said a very good tele screening program for ROP. And look at it. It is 100% very sensitive. You will never miss, and almost 100% of cases for detection of ROP. You see the same thing now with the smaller lenses. You will never miss a case, and you will. Or now also we are talking about treatment requiring ROP now, and your sensitivity and specificity now in most of recent studies after 2010, they are 100% or close to. Now, the same thing for inter-observer change, sort of agreement. The same thing if I examine with my indirect thermoscope, and then Dr. Yahya examined the patient after me, we might have some disagreement, especially for early, let's say, plus disease or early ridge. Is it a ridge or a line? And the same thing for the interpretation of digital pictures. But now this is all they found with experts. The agreement is with interpreting digital pictures is more than inter-observer difference when we are examining. And this was then also compared with the cryo-ROP studies. And now also there are computer programs, softwares designed to aid in the also in the evaluation. And now there are software for the caliber of the width of the blood vessels and of the tortuosity. For many, in fact, tools with the RedCam and other also digital systems. We have the ROP tool with the RedCam, the RESA, and the others. So now even we are getting into the computer will tell us what stage plus disease or otherwise. And the real world of telescreening, I think now it is very well accepted. And now there are before the start of the telemedicine, some of them they will say, no, I will not base my treatment on digital pictures. I need to have indirect thermoscopy before each treatment decision. But now they they screen, they treat based on or decision for treatment based on digital photos only. Okay, now this is very good. This was done in Germany, and also they compared the digital camera as well as to the traditional ophthalmoscopy, and they found, in fact, earlier detection by the digital systems, and many studies. This is from San Francisco. It is called Sundrop, and you can read about from the Auckland, Greater Auckland. Now they don't do any indirect thermoscopy at all. All digital with the reading center, and then they will decide of whether to follow or to treat. This guy in his state of India, Kid Rob, he in fact with the wide angle fundus camera feed it to the microscope to the computer, and then also send it through the mobile devices to the readers, and they can read, and then they send the information back almost instantaneously to the NICU as well. And this is what you will get. You see, standard. This is for the right eye, left eye, posterior pole, temporal periphery, nasal periphery, left eye, and then you can do. You can if you want sort of live in action, and this is the anterior segment. We can do also with the red cam, and this is the pupillary membrane Dr. Saad talked about, and what this is in fact the remnant of the anterior fasciculosa lentis, these lines, and that's why if very early prematures, this will be quite dense, and sometimes they don't allow us for very good view posteriorly. And but mind you, also that's why we are not using the argon laser, which has a green wavelength. This can be absorbed. The laser can be absorbed by these blood vessels and burn the lens, and this was the cause of cataract. So you have, and it is not only a one-man show; it is a teamwork. And you have photographers. Now, in some of the papers you saw that the one who's taking the shots is a ophthalmologist, but now most of them, or all, they are either nurses or, in fact, technicians, photographers. And in fact, the first time when we introduced, many years ago, more than probably 15 years, when we introduced the red cam in the university, I asked the in ICU nurse. She is not an ophthalmology nurse even. I told her, I want you to pick up this camera, dilate it, put the speculum, and hold and take. Once you will see a red spot. I mean the optic disc. Just make it in the center and take a photo. I didn't hold her hand, just verbal instructions, and she produced very nice shot. And hopefully I will show it later. But it is very easy to use, and then you can upload it to the system. And in fact, this is how they work there. And then in the reading, in the office, or even in your home computer, you can access and then plan the management as well. And this is what we propose. And hope now we are working with the Ministry of Health to cover. And now we have almost 5 red cams for the Ministry of Health we are talking. And now we are planning to cover all the regions, and then all level 1 in ICU in the kingdom. We have 30 level 1s in ICU where very critically ill patients, new prematures are served. To get cameras, red cams, wide field red cams or Phoenix or whatever, and then we have it into a virtual reading center. And then from there we feed back the information of our plan, either see after 1 week, or 2 weeks, or needs treatment, referral for treatment, or treat. And this is, hopefully this will save a lot of effort, time, and money as well. And it will be, also decisions for treatment will be very quick. And with this, I hope that this will be applied, and now we have, in fact, few centers getting these cameras, and it will come, inshallah, shortly. And thank you for your attention, and hopefully we will have a good time for discussion.